expanding their learning capacity. So whether you're taking on GP trainees, med students, or foundation doctors, or you are hosting some of our paramedic placements or nurse placements, there's a new process that has come into effect recently. I was part of a pilot scheme about 2 years ago, which looked at training hubs being the approvers for learning environments, because that's the way NHS England wanted it to move, is that training hubs would be in charge of the approval of learning environments. And so the new process will replace the old process by way that the Midlands GP School Deanery approves. They are still part of that process, but any new environment or expansion of learning environment, so an associate practice, has to undergo a new approval process. I will share my screen with you. If I can find it. You see that, Mel? Yeah, okay. So this is, sorry that this is so blurry, but this is essentially the new process. So if you've got a new GP trainer, if the learning environment has already been approved and you're already hosting students, then it follows the old process. So the educational supervisor just needs to be approved. But if you haven't been approved, or you're an associate practice, or you're looking to expand your learner cohort, so having paramedics or physios or nurses, then this is where we would need to be involved. So you would contact the training hub and kind of put yourself forward to be a new learning environment, and you would fill out the learning environment application form, which links to the quality strategy, the 6 domains for quality and governance for education. And then as a team, we look at that application and look how it maps to the domains, and then we would come and do a visit, and we may ask for extra bits of information. So we recently did our first approval at St Luke's, which was an excellent practice as our first one, and they've recently received a learning environment approval. So once we've done our assessment and we come out to your practice, our recommendations go to the locality NHS England Workforce Training and Education Quality Panel, and they would look at your application, look at our recommendations, and either give you advice as to how you need to improve to then get the approval, or they would rubber stamp and approve you. And then every 12 months you would do a self-declaration, and part of that would be feedback from TPD that we would need to see, and feedback from learners, so that we can ensure that that quality is still being met. In terms of our support to you, we have a web page now purely for learning environment approvals. On there is all the information that you would need. So the application form, what to expect from the MDAT visit, rough timings. So the quality panel meets every 4 weeks, normally the last week in the month, and it takes them about 2 weeks to come back with a decision. And so the whole process takes about 12 weeks from us, our first contact with you, you putting the application in, us reviewing the application, either coming back to you with some more information that we need, or for arranging a visit. Then we go to visit you, write our summary and comment, and then that goes to panel. And then once you've been approved, as I say, it's just a yearly application. A self-declaration. In terms of if you're already approved, when your 5 years comes up, then you would just need to do a self-declaration in the same way, and then that would move to annually. And it's the same. We would just need a TPD feedback and learner feedback just to show that you are meeting those quality standards. So if you've got any questions, then please email into the inquiries email at the training hub. I currently lead on this just because I was part of the 1 year secondment to take it on, but all of the team are well versed in how to manage these applications. So if there's a day that I'm not in, if it goes through to the inquiries hubs, somebody else will pick it up. The other thing to just comment on, not to do with learning environments, is there are still 5 fully funded advanced clinical practitioner master's courses that are available. So if you have any members of staff within your team, within your practice or PCN, that you think you would like to develop into an advanced clinical practitioner that would receive the digital badge, and you could use them as part of your PCN, those places are available, both apprenticeship and the standard route. And we also have places for the non-medical prescribing course, both for allied health professionals and for nurses. So we're starting interviews this week. But if you have any members of staff that you think would benefit from having that skill as part of their job role, then please make contact and we will interview them. And obviously, again, if you've got any questions, to contact the inquiries email. Okay.
That's lovely. Thank you, Lucinda. It's a great update. Yeah, like Lucinda said, do make contact with us. We've got website pages for everything now, including her non-medical prescribing page with all our audit tools and how to apply, as well as the learning environment stuff. So yeah, do go on and have a look. Or if you're ever stuck or can't find anything, do email us.
Yeah.
Right. Thank you, Lucinda. That was a great update. I believe our next speakers are actually here.
Yeah, just before you introduce them, Mel, just one thing from me with regards to attendance certificates for today. Just want to remind you, the way that we do the attendance certificates is we will be posting a link to a feedback form in the chat throughout the course of today's PLT. If you could fill that in, that's what we use to generate the certificates. So please, when you do so, make sure that you put your name in as you want it to appear on the certificate, the practice that you're at as you want it to appear on the certificate. Most importantly, please make sure you send us the right email address, because I get at least 20 to 25 every single PLT that give me the wrong email address. And if you do that, you won't get your certificate. So yeah, that's it from me.
Thank you, Craig. So next we're starting a little bit earlier, but that's all good in this heat because it might actually make us finish earlier. So I'm going to hand you over to Dr. Miles Paling. I think he's first, and Nikki Stanley from See the Signs.
Hi everyone, thank you so much for inviting us today. So my name's Miles Paling. I'm one of the co-founders and the Chief Scientific Officer at See the Signs. My background is I'm a clinician, worked in the NHS for many years as up to registrar level, working in general medicine and oncology. And then I worked for the British Medical Journal for a few years, translating research into clinical practice as a clinical editor there, and then co-founded See the Signs with B, who's a GP by background. So we kind of have both sides. And today I'm going to be talking you through, I'll share my slides in a moment, about See the Signs in practice and the evidence that we've generated to date about how it's working, as well as thinking about how we think about the problem and how we're addressing that. But while I'm just getting the slides ready, Nikki, do you want to introduce yourself as well?
Yeah, hello everybody, I'm Nikki Stanley and I'm the implementation lead at See the Signs. I will come back on after Miles has done his presentation. I'll share some contact details with you about how you can book training, and we'll have an opportunity to ask any questions as well. But Miles, if you're ready, I'll hand back to you for now.
Great, thanks Nikki. Can I just check everyone can see my slides?
Yeah.
Yeah, perfect. So as I said, just kicking off, we really like to think about the problem, and many of you will be familiar with some of these statistics. Some of them may be new to you, but it's really about how we think about the problem and how it's being addressed by See the Signs. So most people are aware of the statistic that came out of CRUK about 10 years ago, that 1 in 2 people will be diagnosed with cancer at some point in their lifetime in the UK. The critical deciding factor on survivability excuse me, of the cancer is the stage at which it's going to be diagnosed. If you're diagnosed early, broadly speaking, 90% will survive to 5 years. If it's diagnosed late, it's around about 30% at 5 years, even with the best treatments in the world. Obviously, some cancers are more aggressive than others, so some are much worse than this. Some cancers are better than this. So if you take sort of breast cancer, late stage diagnosis, the treatments are better these days, so can produce better outcomes. But pancreatic cancer, you're looking at less than 5% in late stage. Cancer is evolving in the UK, particularly over the last sort of decade or two. So we're now seeing a vastly increased rate of cancer in the younger population. So now about 40% of cancer is diagnosed in under 65s. It's the most common cause of premature death in the UK. The fastest group that's grown is the 25 to 49-year-olds. So we've seen a 24% increase in the last 25 years. To put it into context, over 70-year-olds is about 10%. So it's increasing at more than double the rate. In terms of early diagnosis, we're not doing that great. It's at about 58%. That hasn't shifted a lot, according to the Darzi report that came out a couple of years ago, in the last sort of decade or so. The main thing that's really driven a couple of percentage points has been the lung cancer screening, but otherwise it's remained fairly flat. Stage of diagnosis also influences cost. So if you diagnose a patient early, they are likely to be about £6,000 cheaper to treat than a late stage cancer. And that's purely talking about just the treatment costs alone. So the surgery, the chemotherapy drug, the radiotherapy session, not about all the other sessions that go into that treatment. But critically to remember is that 95% of patients are diagnosed symptomatically. And I'll talk to you a bit more about screening in a moment. From a See the Science perspective, we like to think about the sort of journey of the patient that they go on from early stage to late stage, and how we can think about these stages and what the interventions available at these different stage points are. So, as I just mentioned, screening is available, with the now 5 screening programs, including the sort of the sample PSA population that's been recommended. That covers cancers that have an incidence of 50%. So 50% of all cancers are covered by screening programs, but they only diagnose 5% of all patients with cancer. So even the most prevalent screening program like breast cancer, it only detects about 30% of patients with breast cancer. The rest present symptomatically into primary care or elsewhere in the system. They are very good. So 95% of patients are diagnosed early, and the reasons for patients not being diagnosed in screening programs, some of it's about thresholds, the age thresholds that they are set on. Some of it's about interval cancer, and obviously a big proportion is patients not taking up screening in the first place. But we have to rely on symptoms for the majority of patients. When symptoms first start, they start with the patient. And the patient needs to overcome the barrier to decide that they're actually going to see someone about it. And that is an individual choice for patients. There are many different reasons why they seek medical intervention. Here are some sort of common themes that sort of arise when the research analyzes these. So they can be things like interference with life. So they may be, change in bowel habit, which means it's very difficult to now go to work. Symptoms becoming intolerable. So that may be pain becoming unbearable. There may be sanctioning, so someone may have told them you need to go and see the doctor. So that might be a partner, a friend, a parent, a child that's told them you should really go and get it checked out. It may be a TV advert that says go and see someone about these particular symptoms. And some patients do this thing called temporalizing symptom duration, which is basically making a contract with yourself to say, I'll go and see someone if it's still here in a week. But many of the early symptoms of cancer can be non-specific, and they're very easy to wash away as being expected as a sort of natural life event. So fatigue is a very common one, early stages of cancer. Patients may put that down to, well, I'm getting older, I'm likely to be more tired than I was before. Weight loss may be seen as a benefit and say, you know, I've lost weight, I didn't even need to do anything, how great is this, that kind of thing. Appetite loss may be put down to stress at work or in family life, etc. So there may be a lot of attempts to explain away these vague, non-specific early symptoms of cancer that may not necessarily mean the patient presents early. And often patients have symptoms for 2 or 3 months before they actually seek help with them. Once a patient finally gets up the courage or is able to visit primary care, it's extraordinarily challenging for primary care clinicians, whether that's a GP, trainee, or whether it's one of the multidisciplinary team seeing these patients, because cancer is not one disease. It's 200 fairly different diseases that can all present in completely different ways, with virtually every single symptom under the sun that they can present with, and they can mimic virtually every other condition that's going to. So they can mimic infections, inflammatory disease, neurodegenerative diseases, whatever it is. Usually another disease can present in exactly the same ways, and often those diseases are more common than the cancer in that patient. On average, a GP will only diagnose 8 new cases of cancer per year. That means out of the maybe 200, maybe, you know, if you're seeing a lot of patients, 400 a month, you know, you might be seeing 400 or 500 patients before you're actually diagnosing one case. So you're really identifying a needle in a haystack. And when you come to the rarer cancers, you're only likely to see one in a lifetime compared to the sort of like top 5, which are most likely to occupy that 8 list. And then that's reflected in the challenges reflected in the data that comes out. So we know that about 45% of patients are missed on their first appointment. 20% of patients have to see their primary care physician 3 times or more before they're diagnosed, and that's particularly challenging given the continuity of care challenges in primary care these days. So you often are not seeing the patient, you know, on the 2nd or 3rd appointment. It's another colleague, at which point they are making their own judgment on the previous presentation. And it's much worse outcomes in terms of the number of appointments that patients need to undergo if they're from deprived populations, ethnic minorities, English not a first language, and other conditions like learning disability, mental health disease as well. When a patient is referred via the urgent suspected cancer referrals, used to be called 2-week wait, we are almost on target as a nation for the faster diagnostic standard, which is the ability for us to diagnose or exclude cancer within 28 days. So we're at about 79%, the target is 80%, so very close. But that still leaves a fifth of patients not hitting that standard. And the reason why that standard is in place is because it's so essential to get patients on track for the treatment standard, which is the 62-day standard. If you miss the 28-day standard, you're far more likely to miss the 62 days. But just on the FDS as well, if you have cancer, you are more likely than not to be in the 20% that don't meet the target rather than the 80% that do meet the target. So you're much more likely to not have cancer if you're excluded within that 80%. For the 62-day standard, we're still fairly way off that. So we're at about 80, we want it to be 85%. We're currently about 73%. That leaves almost a third of patients not receiving their treatment within that sort of 2-month period. And that gives, you know, the patients will not start reversing or course correcting until treatment actually starts. Their cancer will still progress until that moment happens. The final stage of this, and the worst place that you can be diagnosed really is the emergency room in A&E. Currently, about 20% of patients are diagnosed, or 19% of patients are diagnosed through A&E routes. And the problem is that almost all of those patients are late stage. Excuse me. There's about your chances of survival, I should say, at 1 year are 40%. So you can imagine, as I showed you before, 30% at 5 years. If you're diagnosed in A&E, it's 40% at 1 year. So it's a real cliff edge if you're diagnosed there. What's really interesting is that the research that's been done has shown that 66% of these patients, so 2/3 of these patients, have been seen in primary care in the 12 months preceding that A&E admission with accelerating symptoms. So highlighting the opportunity that we may be able to capture these patients earlier. And the broad statistics that come from the research suggest, and this won't be true for every single cancer, but on average, for every month that a patient delays diagnosis, their chances of dying from that cancer increase by about 10%. So it's really important to move as far as we can to the left-hand side and capture those patients on that first appointment. So see the signs. Our mission is to give everyone the chance to survive their cancer. And we do that through 3 main products. I'm aware that in Northamptonshire, it's the point of care decision support, which is what I'll show briefly in a moment. So we have the point of care decision support platform. That's to help guide real-time decisions for healthcare professionals in primary care, whether that's GP, advanced nurse practitioner that may be seeing patients or other healthcare professionals, to risk assess, refer, and then safety net patients that are on cancer pathways. We also have platforms that facilitate patient assessment. So before, in that sort of segment that I mentioned of patients starting with their symptoms, so to be able to catch them even earlier. And we also have a population case finding system, which allows us to identify cohorts of patients that may be at risk of cancer that can be navigated either that are eligible for screening, can be brought back to primary care, or can go directly into patient assessment pathways. Just to show you the point of care decision support, which you have access to. So it's integrated with System 1 and EMIS as a toolbar. You can risk assess on system or search. So search is for where you can just search a particular symptom that may be vague and non-specific. For system, it collates the symptoms, risk factors, signs, and investigation results around bodily systems, how we clinically think. You simply tick off what's positive for the patient, and then we immediately give you a risk assessment that's configured to your local pathways. And we also configure that down to hospitals available. So if you have a local hospital, we'll configure to those particular referral forms. We bring through your referral form, we pre-populate everything. And there are patient information leaflets that you can SMS or email. If you have an email or SMS in the patient medical record, it brings those straight through. We can also mandate fields on those referrals to make sure that they are complete enough for secondary care, so they don't sort of bounce back into primary care. And then everything is saved back into the medical record to keep that as a single source of truth. We also have a safety netting dashboard. So when a referral is completed, we have an inbox feature which notifies administrative staff of the referral, so they can book the referral on ERS rapidly. And then we have a safety netting tracking dashboard. The first board is the active board, which essentially tracks all patients that are on cancer pathways. So whether that's referral or investigation. If it's set up correctly, we can extract a lot of this information directly out of the medical records. So when those results come back, we also have a fit tracking board to track those errant fit tests that are often sent out but never returned, and then can help facilitate the referral if it's raised. And then we have a cancer confirm board that can help facilitate cancer care reviews, as well as maintaining a cancer register in your practice. One of the things that will be coming later this year, we hope around September time, will be centering around Jess's rule. Many of you will be familiar with this, having hit the news, and some letters went out, I think, at the end of last year. around a case called of a patient who was diagnosed very late called Jess Brady. She was, I think, in her 20s and was diagnosed with very late stage cancer, but had seen over a period of about 6 months, had seen her GP GP practice about 19 times before she was eventually diagnosed with cancer. And it was at a very late stage, and sadly she passed away from it. So Jess's rule really centers around the continuity of care that I was mentioning earlier, and around this and considering a 3 appointment threshold for if a patient has seen their GP or the primary care team 3 times or more with similar symptoms, that it should flag a wider consideration of other diagnoses, including cancer. So the way we will be implementing this, if this is EMIS, System 1 works exactly the same. You bring up the patient, we are able to identify that this is their 3rd consultation. We're able to identify the features within that consultation to highlight the symptoms that they may have presented with, which you can add, and then it will take you right through that diagnostic journey. I know that was super quick, but just to show you once more. So patient comes up, we automatically flag. You click learn more to show you which consultations it relates to and the symptoms they present with, and you can go straight through into risk assessment to identify the patient's at risk or not at risk based on those 3 consultations. So in terms of the evidence that See the Signs has generated, we've done quite a lot of studies at See the Signs, which are in various stages of publication. One of the largest studies we did was with 122,000 patients that had been risk assessed through See the Signs to look at the accuracy of the system. And we were able to show that out of the patients that were risk assessed that turned out to have cancer, 99% sensitivity was able to be shown. So out of 100 cancers patients, we would lock on to 99% of them. The accuracy of our system, so obviously I showed you the system showing the recommendations for that patient. The accuracy of predicting that tumor origin and that recommendation, so whether it's a test or whether it's a referral, is 94%. So 9 in 10 times we're able to advise you down the right line of what to do for that specific patient. And then an independent study was performed by a health economist that was commissioned by the Health Innovation Network in the East of England to look at the return on investment, and actually based on redirecting patients and the earlier stage diagnosis, which I'll come on to, we're able to show for every £1 spent on See the Signs, you see an £8 gain within the NHS. And then finally on this slide is about time to diagnosis. So as I mentioned before, that FDS is really important to achieving the 62-day standard. And in specific pathways we've analysed, we've been able to show a 20 to 50% improvement in the FDS through using See the Signs. One of the first things that we did to evaluate the improvement in early stage detection for See the Signs was to look at the cancer detection rate. If you're not familiar, the cancer detection rate is the proportion of patients that are diagnosed in primary care versus elsewhere in the system. And when I say diagnosed, I mean the diagnostic process started in primary care. And there's very good evidence to say that patients that are diagnosed in primary care have earlier stage diagnosis as well as better outcomes. So the best outcomes of any patient, wherever they're diagnosed, whether it's incidentally, is screening, but outside of screening for symptomatic patients, it would be a primary care route. So seeing improvements in the primary care detection rate is a real barometer of early stage detection. So some of the early studies we looked at were specifically to look at the cancer detection rate because we got in-year data from Public Health England, as it was then, and through the Fingertips website. And this just shows you in Suffolk and North East Essex, as it was then. Now it's become Suffolk and Norfolk, or Norfolk and Suffolk ICB. We were able to show an over 12% improvement in the cancer detection rate against controls within the site, as well as NHS England. Similarly, for socioeconomic deprivation, we were able to show in these sites, we're similarly able to show an improvement in cancer detection rate in year in that tracking. And then similarly, this continues. So we're able to look at a bit of a continuous line for this site in Manchester, where the cancer detection rate improved by 12.9% over the 2-year period. They were also able to look at the stage at which patients were being diagnosed, and it was an audit at the end of this period, but it was able to show between the early stage detection in Greater Manchester, they were tracking about 5% ahead of them, and this is a fairly deprived population that would usually track below the Greater Manchester area. I mentioned before about the faster diagnostic standard. We looked at this carefully in Somerset to improve their referral pathway, particularly around colorectal referrals, which were taking a significant amount of time. The FDS was around 46% before See the Signs, and then we were able to shift that down or up, I should say, to 69.5%, so almost 50% improvement. And the days that it was taken to triage a patient, which was one of the critical factors that secondary care was reporting, was changing from 6 days to sometimes even up to 20 days, was now happening in 24 hours. One of the other critical things that See the Signs does, because we are level setting the referral practice across an area, it's also about redirecting patients not always directly into USC pathways, but straight to test pathways first. So whether that may be a simple blood tests or x-rays, scans that are available locally, to non-urgent pathways that may be available or may be recommended through NICE guidance, as well as patients that aren't at risk of cancer as determined by the guidelines that are available. We're actually able to redirect about a fifth of patients away from services on the basis of this. And that also showed that the conversion rate was significantly higher. And whilst the comparison, the conversion rate of NHS England is around 6%, a conversion rate 8 to 7% sounds like it's a tiny, small number. Actually increasing it by 1% would result nationally at about 1 million referrals being not needed to achieve the same outcomes that we're currently seeing. So it's a massive change in the numbers of referrals that you need. One of the biggest studies that we've done and most important studies that we've done, and this is to be published formally hopefully later this year, but we published it in an abstract at ESMO last year, was what's called a difference in difference study, where we looked at staging before See the Signs was implemented, and then 3 years after See the Signs was implemented. Often staging takes time to run through, mainly because stage at diagnosis, if you implement a system like See the Signs in year 1, patients that are already in stage 3 and 4 are already there. So we may be able to detect them on the next appointment, but they're already in that later stage. And you see gradually, year by year, patients move from 4 to 3, 3 to 2, 2 to 1, etc. As they move through. And so you often see this over a multi-year period. We looked at before COVID, because we knew COVID was going to distort the information considerably. But we were able to show that early stage detection improved significantly from USC referrals going from 58% up to 80%. And actually, many of these cancers were in the cancers that are most difficult to diagnose early, that have the poorest outcomes, like lung cancer, ovarian, colorectal, pancreatic, but also some of the most common and possibly considered easier to diagnose cancers like breast and endometrial. They also saw significant increases. So hopefully I've given you a bit of an idea about See the Signs, the data that we have, as well as the sort of the problem that we aim to solve. But I'll be happy to take any questions, but I know, Nikki, you've got a couple of slides to present first, so maybe we'll do those and then happy to open it out to questions.
Yeah, thank you, Miles. I'll just quickly share my screen. Hopefully everyone can see that. So I just wanted to introduce myself again. Many of you across North Hampshire have met with me already, and we've done some training sessions within practice, and also done sort of one-to-one calls with myself to go through the setup, how to get started on See the Signs. If you scan the QR code, I will share these slides with you again. You can book directly into my diary if you want to book some time with me to go over that process again. See the Signs dashboard should already be on your desktops, and you can click that to open. And passwords, as long as your data agreement has been signed, has been sent to practice managers. Now, I appreciate that might be some time ago, so if you don't have those passwords, feel free to make contact with me and I can get those resent to you. I'm also more than happy to sort of do any training sessions within practice, whether that's over lunchtime or one of your practice managers meetings. It's only about 30 minutes, so it doesn't take up too much of your time, and we can go over how to use the platform, how to risk assess, use those referrals and safety net as well. So yes, have you got any questions for us? I can see there's a couple in the chat. So let me go through those. Bear with me. So Miles, this is probably one for you. So the first question is, fatigue is a common presentation in primary care, and is there a tool or suggestions of how to navigate through the to exclude cancer? So obviously that's probably a good way to use our risk assessment to do that.
Yeah, absolutely. So fatigue is super common. From a cancer perspective, you can use the risk assessment side. So the search functionality allows you to look at symptoms in isolation where they may cross multiple systems. So fatigue is a good one, and it highlights which sort of cancer systems to look at. Obviously, there are other causes of fatigue outside of cancer, such as thyroid, anemia, etc., that you may also consider as in that workup. But certainly from a cancer perspective, it can give you more clarity using the See the Signs risk assessment.
Okay. Message from Emily about passwords. So yes, they will be sent to your practice managers. Again, if you don't have those, do just let me know and I can get those sent out for you. Katie's asked whether the tool is available on EMIS as well as System 1, and yes, it covers both clinical systems. And there's a couple of questions around the demo and the slides, and we can share those with you following this call. And again, if you want to book any time with me to go through a full demo, I'm more than happy to do that with you as well. One for you again, Miles. I think it's around Jess's rule. And sort of the see the signs aspect of it. Can you explain more about how it works? How can See the Signs know when a patient presents with a problem they're presenting with? And obviously highlights that there's lots of patients that present with multiple times with long-term conditions. And how can See the Signs tell when the presentation is a recurring undiagnosed symptom?
Yeah, absolutely. So it detects through the integration that we have with eMedicine System 1 in terms of the medical record to detect the presentations that have occurred, so the appointments that they've had, as well as the symptoms that they've presented with. And we can recognize those symptoms as being cancer-related symptoms to highlight that notification. It's quite discreet. So if the patient is presenting with recurrent presentations with COPD, which can technically be a presentation of cancer, as COPD patients obviously are smokers or ex-smokers, and can potentially be, as exacerbations worsen or the condition worsens, it can also be an indication of a lung cancer in the same way that the NG12 guidance would apply. So there is a discretion of the clinician to say, is this applicable in this scenario? And you saw, obviously, it's very quick in the demo, but you can expand to say, why has this patient been flagged? And obviously, if you don't believe that that's sufficient because those consultations have a determined outcome, then you don't need to risk assess that patient. So that there is a degree of discretion for the clinician to determine whether it should be used at that moment in time. But it's been validated in terms of the numbers of patients, in terms of a positive predictive value that it would detect.
And then leading on from that, there's a question around sort of Jess's rule, searching for recoded information or searching for free text. And at the moment, currently, it's just recoded information, but we are looking at the free text at a later date as well. Again, another one around sort of the data. So the graph shows an improvement in cancer diagnosis after implementing See the Signs. It has a false origin and is misleading in terms of the degree of benefit. There are no error margins or p-values. Has a trial using statistics to assess for a significant improvement being conducted?
Yeah, really good point. These slides are summary slides, so apologies, but these were all statistically significant, a p-value of less than 0.05. The full studies are available. Many of these studies were performed independently. They all had independent authors as part of them. So whether that was local representation, whether it was research specialists, whether it was health economic teams, none of them were performed solely by See the Signs.
And Zoe, I can pick this up with you separately, because you've said that your secretarial team aren't getting any sort of notifications to say there's a referral. There should be a pop-up box that sort of notifies your secretarial team separately, so that sort of negates the need to send a task. So I can pick, if you want to sort of just send me your contact details, so I can pick this up with you, and then we can just double check that everything's set up correctly your end. Louisa said, does it recommend a routine referral being needed instead of a 2-week wait?
So it can. It's not extensive. So it's related to usually the NICE guidance or locally agreed pathways for certain symptoms. So there are certain patient groups that are eligible for routine referral. Forgive me, I can't remember the specific criteria, but there's one for urology, which is a routine referral, and I think there's one for another one which I can't remember off the top of my head. But we do recommend those in cases where they are potentially at risk of cancer, but the routine referral is recommended in those circumstances, and that's purely based on NICE guidance rather than and local guidance rather than other routine referrals that we incorporate.
Great. And then I've got a message from Catherine around, would the patient be able to see the Signs recommendations or risk assessments on their online GP record?
So really good question. So the answer is kind of yes and no. So no, they can't see our system. So they can't see the recommendations we show to you. That is for you to determine in the context of the patient what is most appropriate for that patient. It is, but I should say everything that is actioned and that summary that I showed you on that sort of last page is saved back into the medical record, essentially to speed up your note taking so that that can be saved in. It will save it coded, so it will code the test that you're doing. If it's an urgent suspected referral, it will save the fast track code. If it's a fast track referral, we'll also save the suspected cancer. So that's marked on the patient record for future searches if you plan to do them. But only what you action and what is in that final summary will be saved into the medical record. And that's the only thing that would be potentially visible to the patients themselves, not the assessment, as I showed you.
And there's a message from Kelly. Thank you very much for the positive feedback. You've asked sort of about the cancer care review part of See the Signs. So yeah, within the Cancer Confirm board, we do have automated cancer care reviews for both 3 and 12 months. And Kelly, I'm more than happy to pick that up with you so we can go back over that and just make sure that you're happy to have completed those. All those cancer care reviews as well are recorded back into the clinical system as well.
And just to say, if you do cancer care reviews outside of See the Signs, we pull those results into it to make sure it's updated. So it also gives you a sort of holistic view of how cancer care reviews are being performed.
And I think this is the last one, but please do let me know if I've missed any. So it says, please can you give you more information about how the system can be used to audit the cancer referrals from a practice? Can it help to understand prevalence of cancer according to the type of referral or clinician?
Yeah, absolutely. So we have on the practice dashboard, we have a data tab, which essentially tracks the performance data that we're seeing from your practice through See the Signs. That includes things like referral rates, conversion rates of different referrals. It can also highlight the people in your practice that are using it. It doesn't go down to the individual level because we don't want it to be sort of used as a stick for people, but it does tell you who's signed up. So if you do want to make sure that all your practice is using it, it will tell you who's signed up. It also gives you ability to see how you're performing across the PCN. It takes out some of that identifiable information, but it gives you sort of the aggregated information at your practice level to show you how you're performing against different practices within your PCN. And it can also be used in learning sessions that you may have in your practice or PCN. So there's a note-taking function on that data dashboard where you can review that data together and make notes that you can take forward to make decisions on how to improve practice going forward. But if you have a look at the data tab, I'm sure Nikki can show that to you as well in a session about how that works as well.
Yeah, absolutely. And just one thing to sort of bring up is if you're noticing that your the active board, Cancer Confirm board, isn't updating automatically, we might just have to do a little bit of configuration so that the See the Signs and the clinical system can talk to each other. Doesn't take very long at all. We can talk you through that. So again, just get in touch and we're happy to walk that through with you to make sure that's all up and running. I think we've covered all the questions. So I'll hand back over to you, Mel.
Lovely. Thank you both for coming along. We have recorded the session. Just let me know if that's okay with you guys. It will only be sent out to the people that are here today. And then, yeah, if we get any information, I think you've popped your details in there anyway, haven't you? So that they can contact you. That would be fab in the chat.
Of course, I'll do that now, and I'll also share slides with you as well, Mel, so you can send those out to everybody.
Thank you very much. Thank you for coming along, and you finished 10 minutes early, so that's amazing. So what we'll probably do, because our next speaker, I can't see Amit's in there yet, so we'll probably have a 5-10 minute coffee break or a cold water break, and then we will regroup at between 5 and 2 o'clock, and then we'll start the next session. Thank you for putting that in.